Good morning, everybody, on a very classically Seattle cloudy, threatening to rain morning. The good news is we have Andy Pistner joining us today, aka Silent T. Don't pronounce the T in his last name. Andy is somebody I'm really excited to be able to introduce. He is the newest ACHD faculty member, not the newest heart failure faculty member. And he comes to us originally an undergraduate degree at Northwestern and then went back home to the not New York City part of New York, to Rochester for medical school, and then spent some quality time in the Midwest at the University of Wisconsin for training, and then did heart failure training. And this is what makes him particularly unique. One, he's a glutton for punishment of training, because not only did he do internal medicine, cardiology, he then did heart failure and then came to us, much to our excitement in matching him for adult congenital heart disease, and was an adult congenital heart disease fellow with us. Getting a little bit closer to home, he spent a year after finishing his fellowship back in Wisconsin on faculty, and as a perfect fit for us and him, really recognized the opportunities that were available to him here, and came back to join us after a year where he's been on faculty for the last several years. Andy has an exceptionally unique specialty, which it's going to come across today, but it may not be obvious to everybody out there in the cardiology world, that he has a training that maybe 3 or 4 people in the world have in both ACHD and heart failure. And as he's going to tell you, it's an exceptionally valuable combination of things. And that ACHD patients have a disproportionate amount of heart failure, and you can't just treat them the way you treat everybody else. And so he's going to walk us through that. On a personal note, it's not just what Andy knows, but who he is that's been such a great addition to the group. Not dissimilar to his professional life, some of what he does is sort of common, relatively speaking. He goes hiking, he enjoys sports. He's a Bills fan, that's sort of unfortunate. But then he also has these like random little bizarre things that come out over time that really give him personality and connection with other people. He was a Russian literature minor, for heaven's sake, in addition to his chemistry background. He has a fondness for monster trucks. He has, as been identified by a couple of fellows, a ridiculous musical knowledge where he drops all sorts of rando bands and albums and blah, blah, blah. So the things he comes up with to connect with people on has been great, because he's able to make connections, not just with his partners, his peers, but with his patients, which has been just a joy. So he brings his smarts, but he brings his connection. We all do worry a bit about him because of the whole Diet Mountain Dew thing. So if you see him, please help us with the intervention on that, because he's not going to need formaldehyde at the end when he passes, because he's going to be Mountain Dewed to death. But with that, I'm really excited to let Andy have the stage and talk to us more about heart failure in adult congenital heart disease patients, recognizing what a completely unique perspective he brings to this as somebody trained in both fields, committed enough to put the time and energy in to deriving all the training he can to then turn it into the betterment of our patients. Dr. Pistner, Silent T.
Thank you, Karen, for that. Okay. Well, thanks everybody for coming this morning. As Karen mentioned, I'll be talking to everybody here about what does advanced heart failure look like in the adult congenital heart disease population. And hopefully you guys can glean a little bit of the world that we have here and a really coming problem that we're going to have to deal with no matter what our specialty is in cardiology. So I have no relevant disclosures for today's talk here. Objectives here. So first and foremost, I just want everyone to kind of recognize and understand what is the epidemiology of heart failure in adult congenital heart disease, and then just better understand what is the role of medical therapy in this population. Lastly, we're going to touch on some of the barriers for successful heart transplantation candidacy in congenital heart disease. And with that, let's get started. So whenever I talk about heart failure in congenital heart disease, or just congenital heart disease in general, I like to start with some perspective of like, where did we come from? So here on the left, we have Maurice Campbell, and this is one of his papers that was published in 1972. Maurice was the first editor for the British Heart Journal, which later became Heart. Dr. Otto is currently the editor for that journal. And he described in this middle portion of the century, what was going on with his congenital heart disease patients as new surgical interventions were being developed. Because he thought it was important to recognize that when people were going to offer surgery to parents and their young children, what were they offering? What was the life expectancy going to be for these people? And so what you can see here, here's a 50th percentile line I've added. You can see dramatic mortality in the cyanotic congenital lesions of tetralogy of Fallot and transposition. And then you see this logjam in the middle of what we would consider to be simple congenital heart disease, VSDs, ASDs, pulmonary stenosis. And if you look on the left, that vertical axis, you can see mortalities there ranging between the late 20s, maybe early 40s for a median survival. Really sobering, especially when we think about our patients today, we kind of take for granted the success that they've had. However, it's through the works of pioneers such as Helen Taussig, Alfred Blaylock, Vivian Thomas, Robert Gross, Aldo Castaneda, Francis Fontan, and the advances of the medical care for infants and children in the postoperative period. Most children with congenital heart disease are now expected to survive into adulthood. Most of you have probably seen infographics like this. 9 out of 10 children are going to live to become adults who are then going to have congenital heart disease. But even that really doesn't do justice to the success that we've had in the early treatment of congenital heart disease. This is a national registry study here out of Sweden. And they're expecting, and they've demonstrated, that 97% of all the children born in Sweden are living into adulthood. 97%. So keep in mind that if we have 1% of the population in general being born with congenital heart disease, that's going to be a lot of people coming into the adult world. And it's with the success that we've had of surgical treatment of disease that we now are developing all the morbidities that can be associated with these repairs. Things like recurrent or recalcitrant valve disease, pulmonary hypertension, arrhythmias. Anxiety and depression is a huge issue. Mental health is something that we're, I think, only really starting to recognize how much of an issue it is in our population. We also have endocarditis and then heart failure, which I'm hoping to talk to you guys and get you a better understanding for today. So as I like to say, adult congenital heart disease is the consequence of the surgical success that we've had in childhood. And despite the great success we've had, the morbidity and mortality is still significantly increased in this population. Patients still die from cardiovascular disease even after they are so-called fixed. And heart failure is the most common cause of mortality in this population. And yet, advanced therapies such as VAD, transplantation, are still exceedingly rare. So coming back to that, ACHD deaths still due to cardiovascular disease. Another national registry data set that we have here out of the Netherlands. You can see that over 3/4 of patients are still dying from heart disease. Of those who are not, you have malignancy, pneumonia, other kind of potpourri of different problems. And then when you break down the cardiovascular causes, two things really kind of jump out to me when I look at this figure. One, 1/4 of patients are dying of heart failure. These are young patients. In this large 7,000 person registry, the average age of death is only 46. When I think about that number as someone who's starting to look at 46, it gives perspective on it. But you also see a large portion of patients who are dying of sudden cardiac death. And anybody who's working in the EP field or heart failure fields recognize that sudden cardiac death is often a manifestation of their cardiomyopathy. However, the causes of death are not uniform, and they really vary by the underlying form of congenital heart disease and the way in which they are repaired. So kind of color coding this based on that same graph here you had in the past, or in the last slide. And so you can see someone who had repaired pulmonary stenosis, they're not dying of cardiovascular disease, they're dying of non-cardiovascular causes, which one we would all expect. This is a relatively simple problem to be treated, and the residual are usually pretty minor. That being said, you have a patient who has congenitally corrected transposition of the great arteries, and most of these patients are expected to die because of heart failure. We're going to talk a little bit more about that later. And this problem of heart failure is one that only becomes more prevalent over time. The group at the Royal Brompton Hospital in London, which is a large tertiary ACHD program in the UK, looked at the causes of death of all of their patients from the early 90s through the mid 2010s. And then they created this competing risk model. And you can see that even starting in the 20s, heart failure really starts to rapidly accelerate as the cause of death in this population relative to things like sudden cardiac death, acute myocardial infarctions. And yet, despite this large population and a large burden of heart failure, the utility of advanced therapies is kind of shockingly rare. So over the past 10 years, using our national inpatient sample data, we can see that the amount of heart failure hospitalizations in the general population has increased 6%. A real problem, no doubt, simply just because of the absolute number of patients we have. And in that period of time, we've seen a large increase in the utilization of ventricular assist device, 300% increase relative to the number of heart failure hospitalizations. Similarly, we've seen an increase in number of transplants increased by 73%. Again, this is all relative to the amount of heart failure hospitalizations. And then when we look at the congenital population, what do we see? A 46% increase in heart failure hospitalizations. Things that Eric and Karen can definitely attest to that they've seen in their career, that over time, we just see more and more of this showing up. All the fellows here who worked in the CCU, CICU have seen the same thing happen. And in that same period of time, what don't we see? We're not seeing an increase in the use of ventricular assist devices in this population. And relative to this relatively large increase in heart failure hospitalizations, the number of transplants being performed is decreasing. Not great. But what is heart failure? What is heart failure and congenital heart disease? It's a hard thing to really conceptually describe. It's even a harder thing to describe operationally for the purposes of research. I love this slide because you have some real leaders in the field of congenital heart disease describing, for either operational purposes or just general utilization, what their definition is of heart failure. You have some people who are using things like biomarkers, NT-proBNP. Some people are using administrative data sets. And then this is the one that I've used. And I've used this one many years before I even came here to Seattle, not just because I'm working with Karen. So you have a syndrome characterized by either pulmonary and vascular venous congestion and or inadequate peripheral oxygen delivery at rest or during stress that's caused by cardiac dysfunction. This seems like a kind of broad application. You could say that's what heart failure looks like in the general population. And I think that's the idea, right? The heart failure you see in your patients at face value doesn't look different for many of our congenital patients. And so trying to define them as saying that everybody has heart failure is probably just not true, and it's really not useful for every patient. And so how is heart failure similar in the congenital population, and how is it different? Well, the first one that I find fascinating is that when you look at the neurohormonal activation that we have described for decades in acquired heart failure, it looks very similar in the congenital heart disease population. You see an increase in the amount of circulating catecholamines. You see an increase in the natriuretic peptides in these patients. And you see an activation of the renin-aldosterone-angiotensin system, just like you would see in patients with acquired heart failure. And the activation of all these different components increases with their NYHA functional status. Again, just like what you would see in patients who have acquired heart failure. But there are unique differences here in our population. One of them is just the degree in which they have functional impairment. So here's a study that's really kind of a a staple in the discussion of heart failure for congenital patients. On the left-hand side, you have age-matched controls, and on the right in gray, you have asymptomatic adult patients with congenital heart disease. Asymptomatic. And they looked at cardiopulmonary exercise testing, and they looked at the different performance metrics. The most kind of common one that you guys have heard is this peak VO2. So you have young people, these are median age of like 33, have a peak VO2 of 45. And then our 33-year-old congenital patients have a peak VO2 of 26. These guys are asymptomatic. And yet, when they do develop symptoms of heart failure, we see this kind of expected stepwise decline in their aerobic capacity as their symptoms progress. And this is the thing that I find fascinating. When you then add a cohort of acquired heart failure patients and you compare them across NYHA functional classes, their aerobic capacities are similar. So your patient who has repaired tetralogy of Fallot in your estimation as NYHA class 3 symptoms has a similar aerobic capacity when you compare that to a 65-year-old man with ischemic cardiomyopathy and functional class 3 symptoms. So there's some parts here that are uniquely different, some parts that look similar. Which then begs the question. So since neurohormonal activation parallels that of acquired heart failure, will neurohormonal blockade similarly be beneficial? For those patients, that looks similar to the general population in that there are two ventricles with a systemic left ventricle. The effects of GDMT are not well studied. It's really remarkable if you go into PubMed and kind of look for things like ACE inhibitors and heart failure, ACHD. They don't focus on these patients. They don't. But this is one, I think, of one of the better studies that are out there. And this is coming out of the Mayo Clinic. They have 554 patients who have left ventricular systolic dysfunction in a quote unquote normal anatomic set. And then they looked at what happened with these patients when they were initiated on GDMT. And for their purposes, they meant just some form of ACE inhibitor, ARB, and a beta blocker, or up titration of either of those medications. And then they looked to see what happened with the ventricular function of these patients after a year of therapy. What did they find? Ejection fractions went up. For those of you in the EP world, they found that the addition of CRT in these patients also improved ejection fraction. But they also found a decrease in the NT-proBNP, a surrogate that's been used in many different heart failure studies as a secondary endpoint for clinical trials. They also saw an improvement in their NYHA functional classes as well. But heart failure has many different faces in congenital heart disease, or many phenotypes as would be described in the studies. You have those patients who have two ventricles with systemic left ventricular systolic dysfunction. These are your patients who have congenital aortic stenosis, ASDs, VSDs. You have those patients who have a two-ventricle system and they have systemic left ventricular diastolic dysfunction. These are those shown patients that you may see in our clinic. These patients behave very similar to those patients who have HFpEF. And then you have the patients with a two-ventricular system and they have a systemic right ventricular systolic dysfunction. And lastly, we have the single ventricle population, a unique entity in and of itself, the behavior of which both physiologically and treatment-wise is an entire talk. And so with that in mind, I'm going to explore the role of medical therapy in adult congenital heart disease-related heart failure through the lens of those patients with systemic right ventricles. Namely, those are the patients who've had a prior atrial switch procedure for detransposition of the great arteries that you'll see on the left, and also those patients who have congenitally corrected transposition of the great arteries. In both these scenarios, you have a systemic right ventricle that over time, in many patients, will ultimately lead to systolic dysfunction and heart failure symptoms. And there are many trials of ACE inhibitors, angiotensin receptor blockers, and now ARNIs in the patients who have acquired heart failure. This is one of the pivotal trials from Valhaft, published in 2001, looking at the increased survival of patients who have at least moderately reduced systolic function in a heart failure population with the addition of valsartan. And you can see a significant improvement in the overall survival of those patients treated with valsartan. We have tried to replicate these studies in the congenital heart disease population. This is incredibly challenging to do, both from a numbers perspective, a follow-up perspective, as well as just kind of the heterogeneity of the different heart failure phenotypes that you see. So even when we're studying systemic right ventricles, you don't see that they're only exclusively treating patients with atrial switches. It's always going to be some mix of congenitally corrected transposition and atrial switches, simply to get enough patients in there to achieve any sort of statistical significance. So here's one of those studies that was published now a decade ago, looking at the use of valsartan in patients who had both the systemic right ventricle, both different types, and they had to have had symptoms of heart failure as well as systolic dysfunction. And we don't see any improvement in survival. And in this particular study, we didn't see real meaningful improvements in endpoints. We did see some progression of disease in the placebo group, but nothing that's going to be compelling as a reason for us to continue to do it. And this is just a small representation of all the different studies that have been done on this population. And I want to draw attention for just a couple of things. Two columns here in the middle, highlighting the number of patients included and the duration of therapy for the clinical trial. They're small studies. 7 patients that were treated with 8 weeks of losartan. It's no surprise that you're not going to have improvement in any sort of meaningful clinical endpoints with these kind of sample sizes and durations of study. And yet, despite that, we do see some signs that there are effects of these medications, whether that's improvement in their functional status or improvement in the right ventricular ejection fraction. But we're not seeing all the changes that we would expect if you were to extrapolate from the acquired heart failure population data. We don't see improvement in exercise capacity. We don't see a lot of the geometric changes that you would anticipate. What about sacubitril valsartan? Well, as we all know, this has replaced ACE inhibitors and angiotensin receptor blockers as the first-line treatment for patients with heart failure and reduced ejection fraction. Its use in ACHD has been described in really only a few cohort studies. Here's one on the left. We have 40 patients who have moderate systolic dysfunction of their systemic right ventricle, who are either initiated or switched from an ACE or ARB to an ARNI, and then up-titrated to maximally tolerated doses of sacubitril valsartan on a background of other GDMT. So most of these patients are on a beta blocker and an MRA. And what we see is that there is a reduction in NT-proBNP. They recognize that they were never going to achieve statistical significance in the time that they're treating these patients for survival, recognizing that the event rate for mortality in a relatively young population is still relatively low. They looked at surrogate endpoints, one of which was this NT-proBNP. And then we have another here. This is a prospective cohort study of, again, 50 patients who have a systemic right ventricle. And what do we see? We see an improvement in their right ventricular ejection fraction around the order of 6%. Now, when I talk to my patients about switching from their well-tolerated, many years-long therapy on valsartan to say, have you heard about sacubitril valsartan? Tell me more. They don't get excited when I tell them, well, your RV ejection fraction is going to increase 6%. What they get excited about is this next part. When you look at the functional class for these patients at the start of the trial and then through the course of the trial, you see that 50% of patients have an improvement in their NYHA functional class. I think regardless of the ejection fraction, regardless of the NT-proBNP, this result for me is enough to switch all the patients I can from ACE and ARBs to ARNIs in this specific population. Just the relief of the daily symptoms of heart failure in this group is huge. What about beta blockers? If possible, the data on beta blockers in treatment of heart failure and congenital heart disease is even more sparse than it is for RAS inhibition. And I would just summarize it as follows. There may be an improvement in functional status. I suspect there is. Anecdotally, I see that to be the case in many of my patients who have systolic dysfunction and have heart failure symptoms. There is not an improvement in their aerobic capacities. There's not really an improvement in their ejection fractions. But there may be some improvement in the remodeling, whether that's right ventricular sizes, amount of tricuspid regurgitation, various kind of surrogate imaging endpoints you can use in this population. But it's not without risks. Because of the unique anatomy of patients who have systemic right ventricles, they are particularly at risk for developing heart block. In those patients who have an atrial switch, we see that manifested in sinus node disease. In those patients who have congenitally corrected transposition of the great arteries, that's manifested in AV block a lot, and a progressive problem. Commonly stated that 2% per year of patients are going to develop AV block if they have congenitally corrected transposition. So it's not without some hesitation that I think about using these medications unless the patient already has a pacemaker in place, in which case you get them on as much as you can, make sure that they tolerate it. And then shifting gears, I want to review the remarkable success of SGLT2 inhibitors in the treatment of heart failure. We are only now starting to see some of the early clinical trials of SGLT2 inhibitors in the ACHD population, the few case reports, small case series. This is one of the first ones that came out, and it was only published last June, not that long ago. They have 10 patients with systemic right ventricles, and what do they see? A decrease in their NT-proBNP, much in the same way that you'd see in the acquired heart failure population. And it's with this in mind that people have started to do larger studies. So here's a multi-center retrospective cohort study published out of Europe. And you can see that there's great enthusiasm for the adoption of these medications in this population. So there is effectively almost no use of SGLT2 inhibitors up until about 2021, when we start to see some of these trials coming out for the treatment of acquired heart failure. And then you see this rapid adoption of use of this medication in this population. I should make a point here to say that this is not just systemic right ventricles. This particular study represents a broad spectrum of congenital heart disease. A third of them have a systemic right ventricle, but you have 15% of patients have tetralogy of Fallot. Another like 8 to 10% have single ventricles. And these medications are well tolerated across the board. Of all 174 patients that were treated with an SGLT2 inhibitor, 93% of them remained on this medication at the end of their trial period of 6 months. And yet there are patients who stop, and they stop for the same reasons that you would see in the acquired heart failure population, with one notable exception that I have to include. That is one case of Fournier's gangrene that happened in this study. And I would be remiss not to make a mention of this. I recently had to have a pro-con debate about this topic. And as the excellent Luke Burchill said at the Mayo Clinic, no one wants to trade a Fontan for Fournier's. What's the effect of these medications? I think this is striking. If you compare the 6 months prior to the initiation of an SGLT2 inhibitor in this population of 170 patients, and then you look at the 6 months after the initiation, we see that the amount of heart failure hospitalizations decreased dramatically. The hazard ratio, the relative risk in this 6-month period was 0.3. You don't see that. You don't see that in anything else. You don't see heart failure hospitalizations reduced with ACE inhibitors. You don't see it reduced with beta blockers. You don't see it reduced with MRAs. And I think the more compelling part about this is that this is occurring again in a background of GDMT. These are not treatment naive patients. If you look at the amount of patients who are on all three other pillars of heart failure therapy, it's high. And if you then exclude just, just an MRA or just a beta blocker, you're getting up to like 3/4 of these patients are on at least 2 different GDMT medications, not dissimilar from what you'd see in the real world for treatment of heart failure. So it should come as no surprise that with the broad success of these different medications, of the SGLT2 inhibitors, that there are multiple clinical trials, prospective clinical trials that are underway in the ACHD population. What do the guidelines say about the treatment of heart failure in adult congenital heart disease? That you should consult with an ACHD specialist and a heart failure specialist in patients who have heart failure and ACHD or severe ventricular dysfunction. I like to tease Karen about this. I was really excited when this guideline got published. I go straight to the heart failure section. I open it up, and it says you should talk to somebody like myself. And I'm like, oh boy. What is it? What about the European guidelines? I find this fascinating, and this is, I think, just a difference in the way that the guideline writing structure is between the American societies and the European societies. What they did is that they intentionally provided ungraded recommendations, and they acknowledge that. They say the data is sparse. It's not compelling enough for us to say things even on like an expert opinion. We're going to provide ungraded recommendations on what should be done for the treatment of heart failure. And that includes that sacubitril valsartan may decrease morbidity, but they can't say much about the other components of it because of the retrospective or anecdotal nature. Similarly, as I stated earlier, if you have patients who have biventricular circulation, those patients who have systemic left ventricular dysfunction should be treated with conventional heart failure therapy. This is huge. This is the first time you have any guideline explicitly stating that patients who have heart failure and ACHD should be treated like other patients who have heart failure. Not a surprise to say that patients should be treated with diuretics to control volume overload. And then this last one here, I think, is just a fascinating one, that the treatment of symptomatic patients with a failing single ventricle and a Fontan circulation or a persistent shunt, that the medications should be carefully initiated, taking into account the labile balance of ventricular preload and systemic afterload. Very true. Every one of these single ventricle patients that I see who have heart failure symptoms, no one is like the other. The physiologic adaptations to heart failure are unique. The ways in which a Fontan patient fails is unique. You may have one patient who has Fontan who fails because they have development of an inappropriate increase in their afterload, SVR, just like you'd see in heart failure, leading to systolic dysfunction. You may see some people who have obstruction in their Fontan conduit, leading to systemic congestion. Again, a little bit different than you'd see in the two ventricle system. With that in mind, just taking a step back, this is not a recommendation from a society. This is just how I use GDMT in the heart failure population. I really do proselytize the use of SGLT2 inhibitors for basically every patient who can tolerate it. I think the data is compelling across the board from many different heart failure phenotypes, that there is a real improvement in the morbidity for these patients, if not a mortality. But even if it's a morbidity alone, I'll take it. Then for those patients who have a two ventricular system and systolic dysfunction of a left ventricle, I use all the pillars of GDMT just like you would use in someone with acquired heart failure. For those patients who have half picture, again, two ventricles and diastolic dysfunction, I'll use an SGLT2 inhibitor and I'll use an MRA. But I won't reach for our ACEs, ARBs, ARNIs, or beta blockers unless I'm treating other comorbid disease that's necessary. For those patients who have systolic dysfunction of systemic right ventricle, yes, I will use my ACE inhibitors. Yes, I will use my MRAs. I'll have some caution, as I kind of pointed to earlier, just owing to the problems of heart block in this population. But again, if they have pacemakers, full steam ahead. This phenomenon of diastolic dysfunction of the systemic right ventricle is one that I've heard people kind of discuss. It's not described in the literature. Personally, I don't see much of it. And so I don't have much of an opinion about how to best treat these patients. For those patients who have single ventricle physiology, I do think an MRA is really helpful, especially in the balance of treatments of diuretics for these patients, where you can run into problems of hypokalemia. If you're having ascites issues, you end up treating them much more like you would a cirrhotic patient with recurrent ascites. And then the use of angiotensin receptor blockers, ACE inhibitors, ARNIs, beta blockers. I really use invasive hemodynamics to help guide a lot of those decisions. Kind of going back to what I said, that you want to define what is the pathophysiology of your failing Fontan before you just start throwing medication at them. And then those patients who have diastolic dysfunction with a single ventricle, I use our MRAs, I use our SGLT2 inhibitors, but I don't use ACE inhibitors, as the vast majority of these patients have low SVRs, they're hypotensive, they're already as vasodilated as they can be, and I just haven't seen any benefit for them. So that's when we come to the road to transplant. The treatment of heart failure in acquired disease versus that of congenital heart disease is totally different. You have somebody who has acquired heart failure. The first step that you do is you start them on GDMT while you're investigating the etiologies of their heart failure. And then from there, you add on things like EP devices. And if you still have patients who are having recalcitrant heart failure despite empiric treatment for their underlying disease, then you start to go to invasive hemodynamics to figure out what can you add to the situation. And then only after these other things have been explored do we start to think about different structural interventions. Whereas when you look at the patients who have heart failure and ACHD, it's an absolute inverse. We often start with invasive hemodynamics, recognizing that the pathophysiology of heart failure and ACHD is quite varied. There's many different phenotypes of these patients. Structural interventions, whether that's surgical or percutaneous, is usually our first-line therapy for the development of heart failure symptoms. And it is only after structural interventions have been completely exhausted do we start to really utilize our neurohormonal medication, such as ACE, ARBs, ARNIs, beta blockers, et cetera. And when all these things have been exhausted, you have your patients been surgerized as many times as they can be or should be. When you have to ask yourself, when does this patient's heart failure become bad enough that we have to start thinking about advanced heart failure therapies? Well, the European guidelines in the past couple of years have provided, I think, some really helpful operational definitions of what is advanced heart failure. The first of which is in all these things they advise to be present for someone to be labeled as having advanced failure. These patients should all have severe persistent heart failure symptoms, by which they mean NYHA functional class 3 or 4, despite the utilization of medical therapy and structural interventions. They should all have some form of severe cardiac dysfunction. And they actually specifically call out congenital heart disease. If somebody has severe inoperable congenital heart disease as the cause of their heart failure, that should qualify them as having severe cardiac dysfunction. The next component is that of unplanned hospitalizations due to either volume overload, arrhythmias, other manifestations of heart failure. If your patient is starting to have multiple of these, accelerating number of these, you should start to be worried. And the last part is severe exercise impairment. And they define this using 6-minute walk tests or cardiopulmonary exercise testing. And we're really lucky now that we have kind of disease-specific normative values for cardiopulmonary exercise tests. To kind of rephrase that, what we can do is we can compare a patient with repaired tetralogy of Fallot to other patients with tetralogy of Fallot to help better put in perspective their limited aerobic capacity. So why do we include these heart failure hospitalizations? Isn't this just part of having congenital heart disease that you're going to have heart failure hospitalizations? No, not necessarily. The reason that this raises concern in this particular population is that the incident episode of heart failure leads to increased mortality over the next decade in this population. So if you have in this particular study, you have many patients at a large tertiary center. This is at the Mayo Clinic. And they followed patients for a couple of decades. And they found that those patients who had a heart failure hospitalization and then were stratified into this heart failure group, and you follow them, that they have increased mortality. And you can see that these curves separate quite rapidly in the first year and then continue to diverge over the next 10 years. I look at the heart failure hospitalization as both a canary in the coal mine for many patients, but also an opportunity for us to take stock for what is actually going on with this patient. Is this somebody who has intervenable disease? Do they have recurrent or residual valve disease that can be fixed and then lead to alleviation of their symptoms? Their curve probably looks more similar to the patient in red than the patient in blue. Or is this somebody where all their structural interventions have been exhausted and medical therapy is no longer going to be an option? Similarly, we've seen as similar as what you see in the acquired heart failure population, that BNP, elevated BNPs are associated with increased mortality. So in the clinic, what we will often do is for our patients who have heart failure, we'll get serial BNPs for them. So both the absolute increase in BNP as well as the relative change in that BNP are predictive of adverse outcomes. And we see that looks very similar to what has been demonstrated many years ago in the acquired heart failure population. But as I keep hammering home, the many phases of ACHD heart failure really need to be treated differently. And so with that in mind, the ACTION Network, which is a group of congenital heart disease doctors for the treatment of heart failure and congenital disease, have published some recommendations about what things are unique about our Fontan patients and what kind of clinical events that occur should cause you to think about referral for heart failure therapies. And that would be including things like Fontan pathway failure, lymphatic dysfunction, problems called protein-losing enteropathy or plastic bronchitis, ventricular dysfunction, significant arrhythmias, or extracardiac dysfunction. So end organ disease should be a manifestation of Fontan circulatory failure. So when do you sound the alarm for these patients? Well, I think the first step is you have to recognize that there is clinical decline going on, and you do that through a combination of many different factors. You have to take a holistic look at the patient and kind of take a balance of all these different things to say, have things gotten bad enough that I need to think about heart failure? On the right, what you have is a great figure out of the Royal Brompton Group looking at estimated 5-year mortalities for different types of congenital heart disease starting at age 40. So these are all 40-year-old ASDs, VSDs, Eisenmenger patients, et cetera. And the reason why I include this is to give perspective. The ultimate goal is to identify when a patient's morbidity and mortality related to their heart failure is going to exceed the estimated risks of transplantation in that patient. And it makes it really hard, especially in that single ventricle population you can see up there that has estimated 5-year risks that are very broad. We don't really know. We don't know until it's really obvious. And when it's really obvious, it's often too late. To rephrase that, this is one of my favorite titles for an editorial ever. Austin Powers Steamroller, Lessons Learned to Benefit Patients with Congenital Heart Disease, from Jonathan Menachem, who came here, gave a great grand rounds last year. The end has always been a cliff, location of which remains poorly defined. If we knew the location of the cliff and we were prepared for it, the ensuing fall would not be so unexpected nor so dangerous. Many of you guys have probably heard or even used the phrase, this patient has fallen off the cliff. It's not a surprise that they do fall off the cliff. We all expect that patients are going to fall off the cliff at some point. We just don't know where that cliff is. And with that, I'll kind of wrap up with transplantation and barriers for why this doesn't happen more. The first barrier is patients with congenital heart disease, frankly, are just not added to the UNOS wait list. They're not listed for transplantation. So in red, we have congenital heart disease that's increasing, but really slowly. And then in green, we have non-ischemic cardiomyopathy, and in blue, we have ischemic cardiomyopathy. So in 2022, we had 197 patients with congenital heart disease listed for a heart transplant as an adult. In that same year, we had 2,600, almost 2,700 adults listed for non-ischemic cardiomyopathy. So it is with little surprise that with so few patients being listed for transplantation, then we look at the number of patients who are transplanted remains very few, very few. Why is that the case? Well, first, even the heart failure providers don't agree on the timing. Here's a large survey of 400 cardiologists, surgeons, including pediatric cardiologists, asking providers about when would you refer a patient with single ventricle physiology to be seen by a heart failure physician. On the left, we have heart failure providers, and you can see that it's like a 50-50 split, saying that 50% say they should routinely see a heart failure provider. 50% say only if they develop symptoms. And you can see that if you're not a heart failure provider, the number who recommend routine referral is significantly smaller. And then if you look at clinical triggers that maybe would cause one to think that they need to have a transplant evaluation, thinking back to that figure I showed you from the ACHD network, you can see that the heart failure providers very consistently have a lower threshold to refer patients for heart transplant evaluation compared to the non-transplant physicians. So something that were developed, if you had a patient who developed protein-losing enteropathy, most heart failure providers would say, yeah, no, that's a bad problem. That's something that we need to start thinking about transplant. Even if there's going to be a structural intervention that may help this patient, I think it's still good to take a step back and say, let's prepare for the worst while we're planning for a better outcome. And then there's the problem of the challenging anatomy of these patients. A heart transplant is not a trivial thing. And someone said, oh, it's a native chest, like it's a walk in the park. I don't think that's true. But if you have congenital heart disease, it is a whole nother animal. Here on the left, we have a patient who has palliated single ventricle physiology. They have an extracardiac fontan, which is that white tube going from the IVC up to the pulmonary artery. And then they've also developed an ascending aortic aneurysm that has compressed their pulmonary tree, requiring a placement of a large, stiff stent. When this patient gets transplanted, all of that has to come out, and you have to reconstruct your pulmonary tree. You have to reconstruct at times your aortic arch. And this is not something that every surgeon can do. This is not something that every surgeon should do. And so it's not surprising that you'll have patients who have prohibitive surgical risk at one institution that may be an acceptable risk at another. The other problem we have is that of allosensitization. This is the development of antibodies against potential donors. This is one example of a patient. They have something called a PRA, 96%, meaning that you'd expect that this patient has antibodies leading to rejection against 96% of the US population. How are you going to find a donor in this kind of situation? Why do congenital patients have this problem? Pregnancy is an alloimmunizing event. Many of our patients are going on to have pregnancies and successful ones. The use of homografts from cadaveric donors also leads to immunization, prior blood transfusions, even prior viral infections. All of these things can trigger alloimmunization. And that's not even getting to mecanocirculatory support. Lastly, we have end organ disease. The most kind of well-known is that of liver disease in the Fontan population. And it remains somewhat unclear when patients would benefit from transplantation with both a heart or a heart and liver. The reason for that is you have many patients who get a heart only and they get regression of their liver fibrosis and Fontan failure. But there's a number of patients who go on to develop cirrhosis, or they might just have liver failure immediately after transplant, leading to vasoplegia, ascites, things that lead to ultimately early surgical mortality. But we have this combined heart-liver transplantation, which we do here at the University of Washington, that also helps us address the problem of alloimmunization. We are still in our very early days of this, but I'm excited about the prospect of the use of the combined heart-liver transplant, or the HALT program, as you may hear about more, for the treatment of our patients who are highly sensitized. And last is this problem of systemic disadvantages in the UNOS listing. I touch on this one because I think it's not necessarily a controversial topic, but one that's a really charged one. In UNOS, you have patients who are stratified by medical urgency. And for many years, we had the status 1A, 1B, and 2. You guys who are training may not even remember those statuses. Those were changed in 2018. But many people felt like the rules in which you could achieve a higher urgency status were such that the congenital population was systematically disadvantaged, which led to, I think, a lot of appropriate concern, and the data would support this, that the patients with congenital heart disease weren't adequately prioritized and they were dying on the wait list, which led to congenital physicians not seeking heart transplantation listing. And this is a quotation from someone who I respect a lot, for not just their excellent work that they do, but for coming out and actually saying this. And this was at one of our ACHD symposia now a decade ago. And he says, the argument put is that these patients are not dying on the wait list, and so the mortality for the congenital patients is the same as the other patients. Well, of course it is. It's because you're not putting them on the list, and you're not putting them on the list because the listing criteria is such that there is no point in listing them until it is too late. So regardless of whether or not this was a systematic disadvantagement for the patients, there was a real sense in the ACHD heart failure community that they were kind of had the deck stacked against them. We've had some changes in the listing system in 2018, significant ones. However, concerns do persist that the system itself continues to have systematic disadvantages for congenital population. There's a new proposal for further revisions coming up that people have similar concerns for. And with that, I just will wrap up with one thing, and this is, I think, to give hope. As Karen was pointing out when I said, what are you going to talk about? I said, ACHD, heart failure, and transplant. And she's like, are there any like uplifting slides? And I was like, there's some. It's this one. Is that despite all these barriers, despite all these challenges we have in the congenital heart disease population, what we see is that if you can proactively identify the barriers that exist and address those barriers in a institution such as the University of Washington, you can have better heart failure transplant outcomes. So here we have in red the highest volume ACHD transplant center in each UNOS region as a group. And then you look everybody else who does ACHD transplant, and you can see that survivals are dramatically better for places that do congenital transplant. And so I think this makes a real argument for the regionalization of ACHD transplant care in the United States, but also recognizing that it's not a foregone conclusion that patients are going to have bad outcomes. If you work proactively to identify problems, you can prepare for them to have a successful transplant. So to take home, there's a high burden of heart failure in ACHD. Drug therapy is hard to study, but we believe it works in many patients, and I hope I've convinced you of that as well. And lastly, there are unique barriers to transplantation in ACHD, which can be overcome with proactive planning. With that, I need to make some really important acknowledgments. My ACHD group here on the left, there's no other way to say that I wouldn't be here in Seattle if it wasn't for these people. They're incredible. I love coming to work every day, and I hope that when you guys have your careers, especially all these fellows here, that you can find a group like this that gets you excited to come to work every day. We have an amazing group of nurses here just below that they're really our front lines who are communicating with our patients all the time, a mountain of messages and my charts that come in. And then we have Dr. Manami, Dr. Stempino-Tero. These guys have been real mentors for me in the world of ACHD transplant. They've been doing this for years before I ever came here, and they've been helping me kind of figure out my way in my early stages of my career. Dr. Chang and Dr. Pal have been incredibly supportive of the continued development of the ACHD transplant program here at the University of Washington, recognizing that there are increased risks for these patients, but they really believe in what we're doing. Drs. Burke, Dr. Mockley, these are our two surgeons. You cannot have a successful ACHD program without great surgeons, and we have two great surgeons. And similarly, we have Nazem, Neil, and Babik, three of our EP doctors that do the real legwork for all of our EP interventions. They do incredible stuff, and I'm incredibly thankful for them. This doesn't even reach out to all of the many PSSs, PCCs, MAs, sonographers, and others we have in the Heart Institute that allow our program to have the great success that it does. And so for that, I want to specifically thank those guys as well. And then, of course, we have these guys. My beautiful wife, Allie, my little boys, Benny and Nico. They're incredible. They really give me a chance to recharge and come back to work every day. And I can't do this job without them. With that, I want to thank you guys for your attention. I really appreciate everybody who came here today and everybody who attended online as well. This job, I have the easy job here, and I'll wrap up with this. I have the easy job in doing ACHD heart failure. My patients are the ones that have the hard job. They have to kind of take a leap of faith, meeting someone like myself or one of my colleagues, who tell them that it's time for us to start talking about transplant. This is an emotionally charged thing, and they know that through our discussions, it's not a guarantee it's going to work out. And so these are patients who are doing maybe good enough, but not so good that they can take for granted that they're not going to have a bad outcome. And so they take a leap of faith to have a heart transplantation, knowing that there's going to be a chance they may die and they may lose time. They may lose time with their families, with their children, et cetera. And so with that, I want to thank all of my patients who do this, recognizing the great work that they do. With that, I want to thank you guys.
Thanks, Andy, for an absolutely fantastic talk. See if anybody in the audience has any questions. Yes, indeed, Fareed. Thank you for being reliable, my friend.
Andy, that was just fantastic talk. So I kind of an interesting question. So you make a point that there's a lot of heart failure patients in ACHD, yet it seems like whenever something new comes up, it's always first tried in the acquired conditions. I guess, is there equipoise now that, let's say, the next SGLT2 inhibitor or whatever that comes out, that you say, well, look, we just do a pilot study and we do a randomized trial in ACHD. Can we be proactive rather than just waiting for the data? Because now we're in a situation where it's unethical to do a randomized trial of, let's say, an ACE inhibitor in ACHD.
Yeah, I think you hit the nail on the head. And that, I think, partly explains why we don't see a lot of clinical trials for patients like the two ventricles who have systemic dysfunction. What I was going to say is that I think it's challenging because I don't know that there is enough of us in the ACHD realm who also have a foot in the door of the heart failure therapies that we even know that some of these new therapies are on the horizon. Things like, the stimulators we have now for the treatment of heart failure. I think that there has to be more of a bridge between the ACHD and the heart failure communities, so we even know that these things are on the horizon, so we even have the opportunity to be proactive about it. I should also make a point to say that I forgot to include two incredibly important people with our program. Denise Jaffe and Brian Murray are two of our interventionalists and a anesthesiologist who are critical to the success of our program.
Other questions from the audience? Do you want to see if there's... The chat is just a bravo. Oh, wait. I'm going to go Rob, and then I'm going to go Cooper, just because Rob's closer.
Thanks, Andrew. This is a great talk. So being the rat doctor in the audience, I'm going to ask you a mechanistic question. And it's always ACHD, you folks are wonderful, but you've always clearly defined yourself as separate. And I wonder if some ways the concept, what is it mechanistically? What evidence is there? You showed good data that biomarkers are elevated. Why is this just not viewed as one form of myocardial injury that is really at the basis of every single heart failure? And even to Fareed's question, why would we even consider that there would be different responses? And so what is that evidence that the mechanism to heart failure is different in this population, that we should somehow search for a distinct therapy, other than the nuances in therapy?
Yeah, thank you, Rob. I would argue that the mechanisms of ACHD heart failure are unique only in the way it leads to the pathophysiologic changes that you see of acquired heart failure. So the problems of either volume loading, pressure loading, or cyanosis lead to the same problems you'd see in someone who has acquired heart failure. So with one maybe notable exception. If you look at kind of the larger myoarchitecture of a heart with congenital heart disease, and you look at like the arrangements, for example, of the myocardial fibers in the left ventricle, they look different. They look different even in infancy. And that's before these patients have had the adverse remodeling that you would anticipate causing all of the longitudinal problems. I think that there's also an issue of the early sequela of hemodynamically significant disease or cyanosis leads to an abnormal gene expression profile that truly looks like cardiomyopathy in any other acquired heart failure. So you see the same problems of myocardial fibrosis. You see the same problems of distortions of the cellular architecture of these cells. All those things are still present in congenital heart disease. And so I don't think you need to find a different treatment. I think what you need to find is the right patients who are going to be able to tolerate those medications without offsetting some of the unique balances of the hemodynamics of their each form of heart failure.
Andy, great talk. Thanks for thanks for all that. To someone who's done less postgraduate training than you, putting a VAD in a single ventricle patient seems like a reasonable solution because there's one ventricle and you unload said ventricle. Is that a possible route for these patients?
I think that it can be. Let's see if it's going to even let me show you this. Nope, I can't. So I had a slide here I ultimately took out, and it is that of the use of ventricular assist devices in ACHD patients. Frankly, they're not used. If you look at the INTERMAX data, there's a great paper from 2021, which I'll send you guys, that looks at the use of VADs in ACHD. You have over 16,000 acquired heart failure patients have some form of mechanical circulatory support. You have less than 200 patients in that same period of time who have received a VAD with congenital heart disease. And then if you break that down for systemic left ventricle, systemic right ventricle, single ventricles, you're getting into small dozens of patients, which really limits your ability to make statistical inferences there. Broadly speaking, it looks as if they do similar to their acquired heart failure counterparts, and we really should use that more. There just is not enough data, and I don't know if that's an appetite issue, a familiarity issue, or what. But I really think that that is something that's going to need to be explored because of all these barriers to transplantation that I showed you guys.
And I would just add to that, I think that you can make this a priori assumption that it's not going to work technically because a lot of them are systemic right ventricles and you're trying to put it in past the moderator band and yada, yada, yada. Not true, they can do it. Or the subpulmonary ventricle is not up to the task. But it doesn't, the question does not get asked near often enough and hasn't been for years. We are over time. I really want to thank Andy for an absolutely fantastic talk, really given a tour de force of everything that he uniquely brings to the group and to the institution and more broadly nationally. So thanks everybody for coming in person and to those who are online, and we'll see you all next week.